Please unshare your screen, Ashok.
Yes, sir.
Sir, Rajavelu sir and Arsu sir, I think Dr. Shanti is not going to join today, sir. She has some meeting going on. So you both will.
Okay.
Present till the end for the long case, sir, and half for short case. Nizam, can you please start sharing your PowerPoint?
Yes, sir. Yes, sir.
Friends, senior professors, faculty, ETs, and who are watching in the YouTube, thank you for joining us this time. Of having two important faculty, sir and head of the department, general surgery. From Chennai Medical College, Professor RSS, sir. Thank you for joining, sir. Now we have the honor of having the postgraduate kindly contributed by Professor T. Srinivasan, sir. He has kindly contributed. Please take over. Nizam, please switch on video.
Sir, it is the full screen visible, sir?
No, ma'am. You are still in this.
Yes.
Now visible, sir?
Yeah.
Thank you, sir.
Are you okay, ma'am?
Yes, sir. Shall I proceed, sir?
Start. I would request, apart from the examiners, all of you to keep you in mute mode. Senior examiners or senior faculty can definitely add on their points, but let them supposed to be the invited faculty. I would request all the participants, apart from the faculty and presenter, be on the mute mode. Please. Nizam, please start, Nizam. Sir, Rajavelu sir and RS sir, please take over, sir.
Yeah.
Good afternoon, sir. I am Dr. Mohammed Nizamuddin, final year postgraduate from Coimbatore Medical College Hospital, and I am going to present a case of mass abdomen. Before presenting, I would like to thank my professor, my HOD, Dr. Lakshmi Narayani madam and Srinivasan sir for guiding me all this way. Coming to the case, Mrs. A 47-year-old female, homemaker by occupation, resident of Coimbatore, presented with chief complaints of upper abdominal mass for the past 1 year and abdominal pain for the past 1 month. History of presenting illness. The patient was apparently normal 1 year back when she noticed a mass in the right hypochondrium and epigastrium, which is insidious in onset, gradually progressed to attain percentage. History of abdominal pain present in the right hypochondrium and epigastrium for the past 1 month, continuous dull aching pain, non-irritating type, no aggravating and relieving factor, not related to food intake. History of fever present for the past 1 month. It's a low-grade intermittent fever, not associated with chills and rigor, relieved by medication. No history of vomiting, early satiety, no history of hematemesis and melena, no history of altered bowel habits and bleeding fear, no history of yellowish discoloration of eyes and skin, no history of itching, no history of loss of weight, appetite, bone pain, no history of cough, breathlessness, or hemoptysis. Past history. The patient is not a known case of chronic liver disease, diabetes mellitus, hypertension, chronic coronary artery disease, bronchial asthma, and pulmonary tuberculosis. History of sterilization done 29 years back. No history of previous blood transfusion. No history of any medication. History of contact with pets present. Personal history. She takes a mixed diet, not a smoker or alcoholic. She had a normal bowel and bladder habits and has normal sleep patterns. Menstrual and obstetric history. Attained menopause 2 years back. Had obstetric score is para 3, live 3. Puerperal sterilization done 21 years back. Summary. A 47-year-old female with no known comorbidities came with the complaints of upper abdominal mass for the past 1 year with history of abdominal pain and fever for the past 1 month. with no history of jaundice, loss of weight, loss of appetite, and no history of altered bowel habits, with history of concept pets present.
With the history of fever, you said 1
Yes,
month.
sir. Yes, sir.
Ah. Okay.
What do you think?
What?
What do you think? Are you on the basis of history? Am I
Yes, sir.
audible? Am
Yeah,
I
sir.
audible,
Yes,
Nizam?
yes, yes,
Yeah.
sir. Yes, sir.
What do you think are you dealing with? The majority of the times from the by the end of history,
Yes, sir.
you should be able to arrive at some clue to what is the system you are dealing with and probably which part of the system you are dealing with.
Yes, sir.
So from this history, without knowing the physical examination findings, I have certain ideas where to deal with.
Yes,
What
sir.
is your impression if without having seen a patient? What is your opinion?
It may be due to it is due to liver pathology, sir. I would like to conclude from the history. It is due to liver pathology, sir.
How can you say that?
Since it is an upper abdominal pus involving right hypochondrium and epigastrium with history of abdominal pain and fever, it may be due to any infective pathology, benign pathology of liver, maybe due to liver abscess or liver hiatal cyst of liver.
But for such a big mass, you don't have any discoloration of urine or skin color. That is one.
Yes, sir.
And I think from the picture, it is more towards epigastrium and upper umbilical region. And what are the other things that you will have in mind?
I will
Not only with liver, other
yes,
things.
stomach, sir. It may be due to CA stomach, carcinoma stomach, maybe. Or
You said liver benign pathology and stomach carcinoma, is it?
sorry, sir. It may be due to gastric outlet obstruction due to secretion ulcer, maybe.
Nizam, just don't get tensed. Just be like, think that you are in a normal ward rounds. Answer
Yes,
in the
sir.
fashion in which you answer.
Yes, sir.
You said it is 1 year history of fullness or lump. What is your complaint?
Abdominal mass for the past 1 year, sir.
Yeah, some sort of a fullness or abdominal mass, 1 year duration.
Yes, sir.
Generally, anything which is more than generally anything more than I don't know where is the disturbance. Anything which is more than a month usually produces I just changed that. Anything which is I just changed the mode to more. Generally, anything which is more than 1 year, you cannot think in terms of malignancy straight away.
Yes.
Such a huge mass, you cannot think in terms of malignancy. So that is,
Yes,
actually, you have to think in terms of some benign pathology which you have been saying.
Yes,
okay.
Sir. Maybe.
So,
maybe due to acute cholecystitis, sir.
Again 1 year. 1 year and.
Why are you jumping? So acute cholecystitis cannot cause a problem for 1 year. Can you just say a condition which is present in the abdomen, more towards the central abdomen, which can be existing for 1 year and which can produce fever of 1 month duration, which is arising from a retroperitoneal organ, which is more common in alcoholics, would have presented with acute presentation in the past.
Sir has given all.
Retroperitoneal.
What retroperitoneal? Could be a pseudocyst of pancreas, man.
Yeah,
see, anything which is present in the upper abdomen or umbilical region, extension to the right side towards the duodenum.
Yes, sir.
From the history which you presented, without getting into any examination, my suspicion was that I cannot fix in terms of liver mass unless I see that 1 year duration. The duration is for more than a year. That is the one thing which is a clue. Second thing, don't say malignancy in a patient who has got a fullness for 1 year duration.
Okay.
Such a huge mass would have produced a lot of other systemic secondaries and effects of that distal spread of the mass. Rajavali sir, correct?
Correct.
I think
you are right.
You have to conclude to organ on the basis of history. Then only you can go on doing physical examination and general examination.
Yes, sir.
As sir said, it can either be an intraperitoneal from stomach or liver or the structures close by, or it can still be retroperitoneal. Options are open, but most likely a benign pathology because of the longevity.
Yes, sir.
And there was no sudden increase in size in, as per your statement. We'll go on, Arsu.
Yeah. Nizam, anything which is lasting for few days to few weeks is inflammatory. Anything
Yes,
which is lasting for few weeks to few months is malignancy. Anything which is lasting for many months, many weeks to many months is benign.
Yes,
So your case is many weeks to many months. You have that thumb rule. It could
Yes,
be
sir.
most likely to be a benign condition you are dealing with. In
Yes,
general, this is not a rule. Sarcomas deviate. Some inflammatory conditions also deviate. So I'm just saying in general. Okay. Proceed.
Thank you, sir. Coming to general examination, patient is examined after getting consent. She is conscious oriented, moderately built and nourished. Weight is 62 kg, height is 165 cm, BMI is 22.7. Is AF febrile, hydration is fair, no pallor, no icterus, no clubbing, no cyanosis, no generalized lymphedema, no pedal edema, no signs of lymph cell failure. Pulse rate is 72 per minute. Blood pressure is 120/80 millimeter of mercury. Respiratory rate is 18 per minute. Examination of abdomen. On inspection, a mass of size 15 cross 10 cm seen in the right hypochondrium, extending into the epigastrium medially and laterally 3 cm away from the anterior axillary line. Moves with respiration. Skin normal.
Sorry to interrupt. Malik, show me the
Sir.
picture. From the picture, you still want to say it is more in the right hypochondrium or something else?
Epigastrium.
From the picture.
Epigastrium.
You would say epigastrium and upper of the umbilical, no?
Yes, sir.
From whatever you have, the picture you have drawn and you have highlighted.
Yes, sir.
Okay. Moves with respiration.
Skin normal. On leg raising test, mass become less prominent. Umbilicus in midline and inverted. All quadrants moves with respiration. A horizontal scar of size 2 cm over the hypogastrium present. No dilated veins or sinuses. Renal angle free. Hernial orifices are free. External genitalia normal. No supraclavicular forcefulness. On palpation, no warmth, no tenderness. A mass of size 15 cross 10 cm palpable in the right hypochondrium, extending into the epigastrium with the upper border continues with the causal margin. Lower border extends up to 5 cm above the umbilicus and medially crosses midline and laterally about 3 cm from anterior axillary line with smooth surface, well-defined margin, firm in consistency, not pulsatile. And not able to insulate the finger between the mass and the causal margin. And there is no guarding rigidity. Bilateral supraclavicular region, no palpable lymphadenopathy. Percussion, dull note on percussion over the mass. It is continuous with the liver dullness, and liver span is about 18 cm along the mid-clavicular line, and no shifting dullness. An auscultation, no bruit, normal bowel sounds here. Rectal examination, normal sphincter tone, no palpable growth or introduction, and fecal staining seen. Other system examination, cardiovascular system, first and second heart sound here, no murmur. Respiratory system, normal vesicular breath sound here, no adduct sound. And central nervous system, no focal neurological deficit seen. Summary, a 47-year-old female presented with complaints of right hypochondrial mass for the past 1 year with abdominal pain and fever for the past 1 month. No other complaints of vomiting, altered bowel habits, loss of weight or appetite or jaundice. On examination, a mass of size 15 cross 10 cm over the right hypochondrium, extending up to the epigastrium, well-defined margins. Upper border continues with the causal margin. Lower border extends up to 5 cm above the umbilicus with smooth surface, firm in consistency, moves with respiration, not able to insert the finger between the mass and the causal margin, not pulsatile, dull note on percussion with no bruit of the mass. Provisional diagnosis is a case of hepatomegaly, probably due to a benign cause. More likely it was a liver abscess or hydatid cyst or hepatic adenoma.
You have given a differential diagnosis.
Yeah.
So the first we'll take it as the diagnosis. Why do you think it is a liver abscess?
Since there is an abdominal mass or the right hypochondrium and
always start from the age, history, and everything.
Since it's a middle-aged female with the history of abdominal pain and abdominal mass for the 1 year and abdominal pain for the 1 month, and fever on and off for the past 1 month. With on examination, the patient there is a mass of size 15 cross 10 cm over the right hypochondrium, extending into the epigastrium, which moves with the respiration, with not able to insert the finger between the mass and the costal margin, with dull note on percussion over the mass seen. It's more probably it's due.
Is it tender?
Not tender, sir.
Not tender. One. First, you must say why you say it is liver, then why you say it is abscess.
To say it's a liver, the swelling is located in the right hypochondrium and epigastrium location and moves with the respiration and
So
not able to.
Which part of the liver it could be from?
Left lobe of liver.
That is more in the epigastrium.
Epigastrium.
Okay.
Moves with respiration and not able to insulate the finger between the mass and the costal margin. And
Nizam,
yes, sir.
I think, do you think the liver abscess of such a big size to be before discussing the possibilities?
Yes, sir.
Do you think it will be there for such a long duration, such a big size? What would have happened to that liver abscess if it has been in that size? Either it would have progressed or it should have regressed. Two things could have happened. How can it be statically present for 1 year duration? I am not able to accept. Second thing, when such a big liver abscess is there, I have not seen in my entire experience, personally, this is my experience I'm saying, it cannot keep quiet. When the liver abscess is projecting out and it is doom-like outside the liver, every chance of is getting it is ruptured.
Okay.
So I have, and second thing, it is unlikely without any morbid features, it is going on present there. So I think you must revise your diagnosis. If an undergraduate says this is acceptable because, as Rajavelli sir rightly said, you must anatomically locate the lesion, then you pathologically locate.
Yes,
you
sir.
said liver because of the reasons it is why it is liver, but your pathological diagnosis is not fitting it.
Okay.
That is what I feel is not right. I think you cannot put the liver abscess as a diagnosis. Especially second thing, you always never will keep any sort of an acute case in your examination. This is not to hurt the patient. This indirectly you can always get generally. So unless the patient will not be helped, I don't think this is right way of discussing or even thinking. I suppose you are a consultant. You cannot make a diagnosis of a liver abscess in a 1 year history and the liver condition. This is what my opinion is.
Okay, sir.
But second thing, it would have complicated. Okay, it would have complicated. It would not been keeping quiet for 1 year. Yes.
Yes, sir.
Second possibility. What is your possibility? You said
Hydatid cyst. Hydatid cyst of liver, sir.
Why do you say that? Why do you say that?
Since it's a patient, the symptoms for 1 year and pain for 1 month, the patient having the contact with pets.
She gave history of contacts with pets, is it?
Yes, sir.
Oh, right. Okay. She is wearing a dog or she is in association with.
Yes.
Okay. Right. Okay. Then it is justified. In that situation, probably you could have given that as a first diagnosis.
Yes, sir.
See, though abscess is common, you should always think, is it common with this clinical setting? When it is not common in the clinical setting, you should not entertain actually.
Okay.
To be personally, if you make a diagnosis of liver abscess, it may not be you may be on the, I think you may not be right thinking wise as a postgraduate. So you could have put hydatid cyst as the first diagnosis.
But
Okay. Yes, sir.
Also continue.
Yes, no, proceed.
Well, I have one idea. Suppose if you take this as first diagnosis, how will you explain the 1 month history of fever last 1 month?
For hydatid cyst, sir.
Yes.
The patient would have got infections, sir. If it is an infected cyst, the patient would have got fever, sir, for 1 month.
Okay, but a little less common.
Okay. There may be
Any other possibilities?
Cholangitis, sir. If there is any cholangitis,
it would have altered the
jaundice. There will be jaundice.
Yes, there will develop jaundice,
Okay,
and pain will be more severe. They will develop more of fever with chills.
Okay, sir.
And such history is not there. Okay. Keep that in mind. Arsu sir, please continue.
Can you explain? I think Rajavelli sir was asking about hydatid cyst. Can you explain fever in hydatid? Did you answer that question?
Yeah, sir.
I think you said only for those reasons, is it? Yeah. You answered for liver abscess, for hydatid you answered. You answered just now, said it could be hydrated. I think it's a possibility in this setting because it has been silently existing. If there is a secondary infection happening in hydrated, you would have presented to you with fever. Or similarly, in the process of evolution, if one of the cells starts eroding into a biliary channel or a communication, it could have produced a cholangitis. So that could also produce a low-grade fever, or that is a possibility I personally feel. So you have to think of all possibilities. Only investigations can be. What about your diagnosis of hepatic adenoma?
Since it's a middle-aged female, patient has a complaints of about for 1 month, 1 year duration, mass for 1 year duration, and pain for 1 month. It can be a benign cancer, maybe due to hepatic adenoma.
Yeah, as you rightly said, it is more common in female because it is dependent on estrogen. It can grow to larger size, and it's also age group. Also, I think is more often fitting into this age group. Okay, so you concluded on the basis of what are the points to say that it is liver?
Sir, on history-wise, the patient has swelling over the right hypochondrium and hypochondrium and the epigastrium. An examination is the patient, it's anatomically certain right hypochondrium, the mass or right hypochondrium and epigastrium with moose on respiration. And there is, I'm not able to insinuate the finger between the mass and the costal margin, right costal margin, and also there is dullness on the dull note on percussion head of the mass, which is continuous with that of the liver dullness.
Which intercostal space is it enlarged?
Sir?
Which intercostal space is the liver dullness?
Fifth intercostal space, sir.
In case of liver abscess, what type of liver enlargement occurs? Is it upward enlargement of the liver or downward enlargement of the liver occurs in liver abscess?
Upward enlargement will be there, sir.
Okay. Which segment of the liver is likely to be, which lobe of the liver is likely to be involved in liver abscess? Common things are always common.
Yes, sir. Right lobe and posterior superior surface.
Posterior segment of the right is the commonest because of the venous drainage acid drains. That is the most common side. So in all aspects, you will not get, even if you get a big abscess, you are unlikely to get a liver abscess in the left lobe. So the liver is always upwards in the case of liver abscess. Very rarely, the multiple downward never happens. If it happens in the left lobe and huge one, it should have multiple abscess in both the lobes of the liver, not in a single one. Okay, so it's ruled out. Okay. And hepatic hydrated cyst, is there any other, what do you want to do? How will you want to proceed on these patients? Because having seen this patient, how did you proceed? The complaints are only fever and pain for 1 month duration, is it not?
Yes, sir.
More for 1 month. How will you proceed on this patient?
Sir, I would like to do investigation to confirm my diagnosis, sir. First, I would like to blood investigation for in there will be eosinophilia and
what is the first thing you have to do?
Ultrasound abdomen pelvis. I would like to do, sir.
Nijam, always answer in a fashion in which you sit in the OP and think. Never start thinking like a physician. You sit in the OP and see this patient. What first investigation you will write?
Ultrasound abdomen pelvis.
The investigation is the confirmatory one has to be done first. Your eosinophilia, will it ever confirm the diagnosis of any? Nothing. You do ultrasound. What did you do ultrasound in on this? You know this patient. They are following up this patient or not?
Yes, sir.
We will discuss what is the actual case later. What do you expect in liver abscess? What do you expect in hydatid? What do you expect in hepatic adenoma?
Sir, ultrasound will confirm the organ of origin and the nature of the mass. It will be a cystic or solid lesion. If it is cystic lesion, there will be if there is cystic lesion, we also can locate the lesion using ultrasound, which lobe of the liver is involved, and the cystic lesion there will fluid.
What will be there in liver abscess? What will be there in
liver abscess? There will be particulate movement inside the abscess cavity. With in hydrated cyst, there will be septae, or in case of there may be a septae or a separated membrane may be seen. Till a calcified cyst may be seen. In
liver abscess, it depends upon, it could be a solitary liver abscess. More often it is multiple liver abscess. The
Yes, sir.
cysts, there will be abscess of varying size present in both the lobes of the liver or more predominant in the right lobe of the liver.
Okay.
And it will have a lot of hypocoagulation with movement of fluid, Brownian movement of fluid inside secondary to necrosis. This
Okay.
is what you will see in a liver abscess. Okay. Then what in hydatid, what is most characteristic feature of a ultrasound feature in a hydatid?
Water lily sign condition, sir.
Yeah, you will have, see, that is what is characteristic. You will have,
Okay.
you may
Water
have
lily.
single cyst or multiple cysts. Even in a large cyst, you will not have what daughter cyst floating inside the cyst.
Yes, sir.
So that is the characteristic feature of a hydatid cyst. That you can make it out by the presence of cyst and daughter cyst will be the characteristic feature.
Okay.
You said you can also set calcification in a wall of hydatid. Suppose if you see calcification in a wall of hydatid cyst, what does it imply?
It's a dead cyst or inactive cyst.
Yeah, it is an inactive or that portion of the cyst is dead. Okay. Then what else you do? But in hepatic adenoma, what will you say?
It's a solid lesion, sir. In contrast to the liver abscess and cystic hydatid cyst, it is a solid lesion with post-acoustic enhancement will be there. Post-acoustic shadowing will be there.
Proceed. Then you have done a liver. Then you have done an ultrasound. Okay.
Yes, sir. Yes, sir.
On the basis of that, how will you proceed? How will you further confirm? It says liver abscess. It says hydatid. It says hepatic adenoma. What will you do?
I'll like to do CCT abdomen pelvis, contrast enhanced CT abdomen pelvis.
Okay.
To locate the swelling and know the extent of the swelling, and then locate and to confirm my diagnosis, I would like to do contrast enhanced CT abdomen pelvis.
Okay, you have done it. How further you will proceed?
What are the additional information you get it other than ultrasound findings in CT? You have done CT. CT is giving, ultrasound gives a lot of information.
Yes,
what additional information that you get from CT?
Extent of the cyst can be made out in CT abdomen pelvis, and characteristic spokeswheel pattern or cogwheel pattern seen in a hydatid cyst in CT abdomen pelvis.
That is okay. And also you will get any other information that we could have missed. You are still sticking on to liver.
We can look out for any contrast enhanced CT. Sorry, it can be. We can look out for any other benign conditions such as focal nodular hyperplasia, hemangioma, radial slope.
Okay, there are rare conditions, but
yes,
they don't come in this size.
Yes, sir.
Okay. Then
I would like to do serology to confirm my diagnosis, sir.
Continue.
ELISA and
what serology? What in which for to make a diagnosis of which condition do serology?
Hydatid cyst, to confirm a diagnosis, I do serology, ELISA and indirect hemoglobination assay.
What are the confirmatory tests in for hydatid? ELISA.
ELISA, sir. Yes, sir.
What is counter immunoelectrophoresis? There is some specific test for
Okay. Okay. Sir, after confirming my diagnosis for the CCT with the help of investigation, I would like to plan.
Continue.
Yes, sir. If from the CCT abdomen pelvis, it came as an hydatid cyst of liver involving left lobe of the liver of size of 19 cross 20 cross 19 centimeter. 20 centimeter, and I would like to plan the patient for surgery, plan the patient for management. For management, I would like to go for with medical management. I would like to start. I would start the patient on albendazole for 10 days prior to the procedure, and to continue up to 2 months after the procedure. And I would plan the patient for open laparotomy and open evacuation of the cyst with de-roofing of cyst wall, and pericystectomy with pericystectomy can be done.
Can you all? Okay. What precautions you will take?
During surgery, I will pack the abdomen with abdominal pads soaked with squalicidal agent, usually 15 to 20% of hypertonic summing, and fracture, and to prevent the spillage of carefully manipulate the cyst without preventing the spillage of the daughter cyst in the abdominal cavities.
Okay. Can you do this with laparoscopy?
Yes, sir. Laparoscopic pericystectomy can be done.
Okay. Okay, this case you worked up?
Yes, sir. I worked up this case.
And what is the diagnosis was left lobe of the liver, is it?
Yeah, sir. There is in the CT picture of this patient where there is a multiple dorsal cyst with producing cogwheel appearance in the CCT abdominal pelvis involving the left lobe of the liver of size 20 cross 19 cross 16 centimeter with multiple daughter cysts within. And we did laparotomy and open aspiration of the cyst after with the injection of polycidal agent and de-roofing of cyst wall done with partial pericystectomy and omentopexy.
Okay. See, from the very first picture itself, it looked like I was telling epigastric and this thing, but you kept on saying it was right hypochondrial.
Yes, sir.
Okay.
Yes,
I don't think you should have started like that. Okay.
Okay. Okay.
That's one.
So it happened to be a hydrated. Sorry, I got a phone call. I need to leave. So it all fitted into a case of a classical hydratism.
Yes, sir.
Okay.
Yes,
That
sir.
is the only swelling which can be there. So it is a benign swelling. So I've
Yes,
told
sir.
you one simple thumb rule.
Yes, sir.
Anything which is there, instant short duration is trauma.
Inflammatory.
Within
Trauma.
few hours is trauma or
Okay.
bleed. Anything
Okay.
which is there for few hours to few days is inflammatory.
Inflammatory.
Anything which is there for few days to few weeks is subacute
Malignant.
inflammation. Subacute inflammation.
Okay.
Anything which is there for a few weeks to few months is malignancy. Many months is always almost benign,
Yes,
except hydatid or chronic pseudocyst. These are the two things. The way in which you presented such a huge nature, I thought of two possibilities. One is hydatid, and second thing is your pseudocyst of pancreas. Clinically, you must have some diagnosis.
Okay.
Stomach is not possible.
Okay.
As you said, VGP, you should have vomiting, projectile vomiting should have been
Yes,
there.
sir.
Such a mass. It cannot be a static mass all the time.
Okay.
So all those things, you should discuss the pros and cons and making a diagnosis.
Okay.
So I said CA, counter immunoelectrophoresis, one of confirmatory investigation for hydatid, where you'll get a classical precipitation called ARC-5 precipitation, which is characteristic of hydatid. And similarly, ELISA, as you said, these are all about. Never say Cassoni's test. Cassoni's test is outdated. Eosinophilia cannot contribute in making a diagnosis. Your investigation must be confirmatory or has got a true positive pickup rate must be very high, must be both sensitive and specific. So ultrasound itself can. So such a big mass. When did you see the patient? And just say you have operated. As a surgeon, you are seeing the patient. Such a huge mass is there, and you confirm that as hydatid. A single diagnosis by ultrasound is sufficient, or a CT. How will you approach this patient? What will be your approach as a surgeon?
Sir,
your diagnosis.
Yes, sir. I will diagnose the CT. I will, since it's a huge swelling of involving left lobe of liver of 20 plus 19 centimeter, I will plan the patient for open surgery, sir.
Yeah, okay, no issues. Can you straight away jump and do a open surgery?
No, before that, we will plan for medical management and start the albendazole for 10 days prior to the surgery and continue up to 2 months after surgery.
what is the ideal medical management for liver hydatid cyst?
Albendazole, praziquantel can be given.
Albendazole, how will you give? There is a
10,
classical
10,
rationale for giving
10,
albendazole.
yes, sir. 10 milligram per kg body weight.
Very good.
To surgery and to continue up to 2 months after surgery.
Actually, why should you start this patient or albendazole or praziquantel? What is your intention?
Larvicidal or ovicidal before surgery.
Pardon?
The ovicidal, it is an ovicidal agent.
Yeah, scolicidal. Scolicidal. Actually, albendazole should be given in the dose of, rightly said, 10 milligram per kilogram body weight should be given for a period of 4 weeks, followed by 2 weeks of rest. Again, 4 weeks followed by 2 weeks of rest. 3 cycles should be given. We have had few patients, 1 or 2 patients on which we have started. So you can monitor the regression of cyst size by doing an ultrasound. The cyst will start shrinking in size. The crenations of the cyst wall margins will appear in a period of 2 to 3 days. Okay, this is what is can happen. And the idea is, at the time of surgery, you can avoid spillage.
Yes, sir.
Even if there is a spillage, the chances for you to get a dissemination is very, very less. Not only anaphylaxis,
disseminated hydatidosis.
It's very, very less, because this is not a very small hydatid, it's a huge hydatid. The moment you open, every chance of spill is there. And after 4 weeks, 2 weeks, 4 weeks, 2 weeks is given. 2 weeks is because of albendazole is hepatotoxic. You should give 2 weeks for the liver to recover. And recovery of you must monitor the liver function in between, because the liver is already damaged by your cyst. So that is the reason why you can give. You can add praziquantel near the term, near doing surgery. Okay. And you said open surgery you will do. My signal was out. I just went out and came join. How did you approach this patient? This is the operative picture. I'm just asking you. How will you approach this patient if you are a surgeon? You have given him medical management. 3 cycles you have given. You have monitored the patient. You have prepared the patient.
Yes, sir.
How will you operate this patient?
Using a right subcostal incision. Since it is a right hypochondrium and epicondrium, I will open after entering the abdomen and pack the abdomen with the abdominal cavity with the scolicidal agents. So pad mop with the scolicidal agent. And
what are the scolicidal agents? You know,
hypertonic 15 to 20% hypertonic saline, povidone iodine, cetrimide, and formalin.
You can use betadine also. You can take betadine run cloth also. You should take a black color cloth or a dark color cloth. What is the reason?
Sir, to assess the cysto-biliary communication post-op.
The cyst must be able to be seen on a darker background. Darker background. Then only you can betadine potting the darker background vandrum. Sorry. Okay, you have just taken it and filled it all around. Then before doing this, anesthetist கிட்ட நீங்க அம்சிங்கன்னா என்ன எதிர்பார்ப்பாங்க, என்ன பண்ணுவாங்க? What they will ask for? They will try to rule out a pulmonary hydatid.
Yes, sir. Pulmonary hydatid.
Once you have confirmed it as hydatid, you must do a CT test also to think of the possibility of a pulmonary hydatid. Okay, so they would like to ask you to do a CT scan before that. Then, how will you proceed to operate this page? Will you proceed to operate? Enna pannuvinga?
I will inject the after aspirating. I will inject a 23 gauge needle with a syringe to the cyst cavity and aspirate up and to inject the scolicidal agent into the cyst cavity and wait for 20 minutes for the scolicidal agent to act.
What are the problems of injecting scolicidal agents? What you would ideally inject? What are the problems?
Hypertonic saline, sir. Ideally injected. The problem with the povidone iodine and betadine cause cholangitis and
that is the issue. Exactly. So it can produce irritant cholangitis. It can cause. It can cause irritant cholangitis. So then, how long you will wait?
20 minutes, sir.
Yeah, 20 minutes you will wait. Then what will you do?
I will then open the cavity, de-roofing of the skull done and the evacuation of all the darkness.
Any method of opening the cyst with a special instruments? Have you heard of a cone type instrument which is inserted into it so that to avoid spillage? If you open, If you, I'm not able to explain you. If you open straight away, there is a chance for spillage. There is a special cone-like instrument that can be put into the cyst that will avoid spillage. So it will rupture. Once you open, it will start rupturing. You can do a controlled release by a special instrument. You can see in textbooks, and that can be used. Funnel-shaped instrument can be used, can be inserted into the system, can be used to avoid spillage. The entire idea in hydrated is to avoid spillage. Avoid spillage. You can you have done all that and you've excised. What type of surgery you'll do? What is the surgery called?
The peristectomy, sir, with the deroofing of cyst wall with partial peristectomy.
What are the layers of hydrated?
3 layers. It has 3 layers. Innermost layer is endocyst abdominal layer. Middle layer also known as ectocyst or laminated layer. Outermost layer is pericyst or adventitious layer.
The liver's reaction to hydrated is your pericyst.
Pericyst, yes.
The germinal layer is the endocyst.
Yes, sir.
And the in between layer is the laminated membrane.
Yes,
okay.
Sir.
Then you just aspirated everything. Which surgery can cause lot of bleed in this?
Sir, I couldn't get,
which can cause lot of bleed if you attempt to do? If you do a cystopericystectomy through the liver pericyst, it can produce lot of bleed. That is why we never attempt to do. We just open, suck out all the cysts, scoop out all the contents. That is a safer way. And how will you manage a resultant cavity post-hydrated?
Can be marsupialization can be done.
Okay. Marsupialization, if you do marsupialization, what are the problems? There is a chance for spillage. You must be very careful with marsupialization because the few cysts are there. Scolix is there. If you missed it, it can produce a disseminated hydrated.
Okay.
Okay. Right. How will you, what is the other method of filling the cavity? What is capitanage? You take a crisscross bite across the cyst wall. You take from 11 o'clock to 5 o'clock. From again again 7 o'clock to 1 o'clock. It's called capitanage. You can take multiple bites, like a ball of sutures inside. That can obliterate the cavity. That can be done. Momentum can be kept inside, and you can attempt to do that. These are all the. How will you manage a dead cavity of hydrated, especially larger cavities? Okay. Suppose post surgery எவ்வளவு நாள் கொடுப்பீங்க? ட்ரக்ஸ் எவ்வளவு நாள் கண்டினியூ பண்ணுவீங்க?
2 months, sir. 2 months after the surgery.
Okay, you have to continue for 2 months. What is the role of praziquantel?
Again, polycidal agent.
Yeah, it can be given during the period of surgery, just before surgery.
Yes,
that period it is given. It is effectively prevent further spread of okay, pa.
Yes, sir.
Right, and it's a very, very great case you have done. Very, very rare nowadays.
Yes,
what is malignant hydrated?
Malignant hydrated is a misnomer. It's caused by Echinococcus multiloculans. Usually, there will be multiple hydrates in both the lobe of the liver. Very difficult to treat and was problems.
Can you just tell me what is the causative organism for this hydrated?
Echinococcus granulosus.
Who is the permanent host?
Definite host is dog is a definite host. Intermediate host is sheep, and humans are accidental hosts.
Accidental hosts. How does it enter the humans?
Humans, the ingestion is entered by fecal-oral route and is carried from portal vein in portal circulation to enter the liver. Okay.
And then goes to occupies there. Can it bypasses the liver and produce a hydrated in the lung alone?
Yes, sir, can be seen, sir, but very
rarely it is possible.
Yes,
very rarely it is possible. The liver is the first filter. When the first filter it filters, it may occasionally produce in remote areas. We have seen. Only one incident I can quote is I operated a patient in first year of MS. They said soft tissue sarcoma, you take biopsy. I opened the cough of the patient. Under that were coming tons and tons of hydrated, 150 hydrated. But that patient didn't have hydrated anywhere in the body. That was a surprise. We did ultrasound 94, 95. Okay, I think Rajavel is said.
I was about to ask where else you will get this hydrated.
It may present in liver, muscles, spleen, kidney.
All solid organs,
Yes,
muscle, and more importantly, in the, can you have it in brain?
Yes, sir, can.
That will act as a space occupying lesion.
Yes,
It's very rare, but it has happened. And as Arsu sir, I think he neatly, elaborately discussed this case. And muscle hydratation is also quite common.
Yes,
the reason for that is my first surgery in MMC was asked to do a biopsy. I opened, I didn't know what I was handling. Lot of grape-like structures for I have not seen one. I called the assistant. I thought something I have done near the knee joint. He came and said, "This is all hydrated, man. You are lucky you are seeing." I said, I saw the entire 3 years only that patient I saw.
Okay.
So I went through discussions. So I was strongly registered it. So that's what I could give you more tips. We treated the patient thoroughly, and that's what I am saying. Okay, good. But you always, I just wanted to say, me, Rajavelu sir are all colleagues in MMC Stanley corresponding 94-97. Our teachers used to say, always history you will be able to make 50% of the diagnosis. With physical examination, you will make 70 to 80% of the diagnosis. So you should locate the organ or locate the disease process. Both can be done by history. Anything else? Hepatic adenoma, as you rightly said, is more common in females because especially those who are taking oral contraceptive pills a longer period of duration. Estrogen in that woman may take 15-20 years without other methods. They are the women who are prone for developing such a large mass can. Always think of common things and try to correlate with time duration and findings. Because it is liver, you should not say abscess. Whether it is possible to have liver abscess, and I will never touch up this as a liver abscess. Never say. Thank you.
One good clue that you had was it was a big swelling, more than 1 year, and smooth surface. That is most likely to be a cystic swelling in the parenchyma, unlikely to be any other sort of. Okay, that's a clue. Okay. Thank you for presenting.
Thank you, sir. Thank you, sir.
Thank you, faculty. Arsu sir, Raju sir, thank you very much, sir.
Thank you.
Sir, you could have added. You could have added some points, sir.
Add on.
No, sir. I've been quietly watching. I think most of the things are covered. The only question is the principle and policy of the pre-procedure sterilization is continuously evolving. Many times we need to use 1,200 milligram of albendazole on a daily basis. Pharmacies do not supply for 30 days when you write we have gone crazy or something. So albendazole, one more advice is somebody who uses albendazole should be asking the patient to chew and swallow, because albendazole, if you take full tablet, it comes out in full. So these are the two things one should keep in mind. And especially when you are using the sterilizing agent, please inform your anesthetist that you are using sterilizing agent for these courses, so that they prepare some amount of hypotension, amount of fall in pressure, and
I will ask you, Nizam, before concluding.
Nizam.
Yeah.
Yes, sir.
Nizam, how will you manage pulmonary hydrated? My teacher used to ask me, after doing thoracotomy, used to say, who does the surgery? I don't know.
Generally, whoever uses the bag gets the benefit of it.
That's all.
Yes, I don't know. Anesthetist or surgeon, PG, doesn't matter. Whoever has the bag completes the operation in 1 second. That's it.
1 second. Probably nowadays, anesthetist ventilators are the one to be given the credit.
No, sir, but then I would say the PT should understand the importance of closed tip ventilation. Once you have the adequate mobilization of the lung, it is matter of few seconds and few bagging of the lung, which sends out all the hydrated. So that is the most important message the faculty would like to tell here. Sir, any other points, sir, or can we call it a close for the next
close,
case?
sir. We'll close, sir. We'll go to the next case, sir. Only thing I would like to say is the approach was when he made a abscess repeatedly. I'm insisting for watches also. I don't think he should have given that. Is my opinion, Anisa. That is not the way to think as a surgeon. The principle has to be correct. You may be making a wrong diagnosis, but you cannot make principally a wrong approach. Yes, sir, is it right, sir?
Yes,
no, sir.
very true.
The point
Very
is,
true.
this may not be a exam case, sir, because we and Marudhu, sir, we spend some time whether to approve or not. Then they said, when the exam faculty, let them take up the important, as you rightly pointed out, how to rightly approach. Sometimes we don't get a straightforward CA stomach or a right leg for some mass where the diagnosis is more certain. So these are the things we thought over, but then we allowed the candidate to fend for themselves. But of course, there were some definite glaring issues which could not be accepted by any of the examiners. So it is a learning experience for definitely the students and the junior postgraduates who have been in the process of preparing the exams, and many have been relieved. Sir, definitely there are few issues which warranted a discussion, and I think both the examiners took serious note of it and put the candidate back to his line, sir. Thank you very much, sir.
Thank you. Thank you.
Thank you. Thank you.
Sir, Rajavelu sir and Arasu sir, I am sure you are all committed with your work, but I would recommend if you can stay with us for the next case also, I'll be happy. With your permission, we move on to the next case. Ashok is kindly contributed by Professor Jailal sir from Kanyakumari Medical College. To discuss, we have two important professors. Professor Sarda ma'am is a retired professor and HOD surgery. Now she is a professor of surgery at PSG Medical College. Then we have Professor P. Karthik sir, HOD surgery at SRM Trichy. And I'm sure Jagdishan sir will be shortly joining us. Thank you very much, all of you. Ashok Kumar, kindly share your PowerPoint and start your presentation.
Yes, Raghavel sir, I'll leave at 4:30, sir. I have a commitment.
I'll leave most at 4:30. Welcome, sir. Thank you, sir.
4:30, sir. 4:30, I'll leave, sir. Thank you, sir. Thank you.
We will try to finish in 4:30, sir. We are just going to be 2 minutes to 4.
Sir, is it visible, sir?
Not yet, ma. Hi, yes, Kana. Good luck to you. All the best. Shadam ma'am, Karthik sir, please take over.
Yes, sir.
Good evening to everyone. I would like to present the case of carcinoma penis. 71 years gentleman from Nagarkoil, manual laborer. He is presented with the chief complaints of growth over the penis for the past 6 months. History of presenting illness. Patient was apparently normal 6 months back when he noticed a button-sized ulcerative lesion over the dorsum of the glans penis. The lesion was gradually proliferated circumferentially to involve the whole of the distal penis. History of seropurulent foul-smelling discharge with occasional blood staining from the lesion. History of inability to retract the foreskin for the past 3 months. No history of swelling or ulcer in the groin. No history of penile trauma. No history of sexually transmitted diseases. No history of hemoptysis. No history of jaundice. No history of bone pain. No history of loss of weight and loss of appetite. In past history, no history of similar complaints in the past. No history of previous surgeries. Personal history: smoker, 10 BD per day, 40 years. Smoking index 400. Not an alcoholic. No history of IV drug abuse. Family history: no history of sexually transmitted disease in partner. Summary: 71 years gentleman from Nagarkoil, manual laborer. He came with the complaints of ulcer-proliferative lesion. Ma'am?
You say this as an ulcer in the penile region or a growth in the penile region? Usually a carcinoma penis will present like an ulcer. So you have patient's words, complaints, it will be usually an ulcer. They will not say as a growth. So in the complaints, you can change it to an ulcer rather than a growth.
Okay.
And pertaining to the part, the local part which is affected the penis, the more information you can get regarding what is his difficulty in any other local functional disability, sexual disability. All those things also matter before you go into hemoptysis and other things, which is all due to, you think, metastasis, no? So the local complaints also, you have to elaborate more in the history of presenting illness.
Okay.
Proceed.
Summary, 71 years old gentleman from Nagarkoil, Manu Labrador, is presented with ulcerative growth in the dorsum involving the whole of the distal penis for the past 6 months, with the associated serofluid foul-smelling discharge with occasional blood staining from the recent history of recent onset phimosis for the past 3 months. He is a non-smoker for the past 40 years, more likely to the carcinoma of penis. Proceed.
Proceed with general examination.
Yes, ma'am. General examination, patient examined in well-lit room with informed consent. If conscious oriented afebrile, no pallor, cyanosis, clubbing, paid edema, generous lymphadenopathy. ECOG score 1, BP 110/70 mm mercury in the right upper limb in sitting posture, pulse rate 70 per minute. This is the clinical picture of this patient. Examination of the external genitalia, inspection and ulcero-proliferative growth of size 4x4 cm involving the profuse glands, coronal sulcus, and distal shaft of the penis with the irregular shape and irregular margins, is everted edges, surface appears irregular with the areas of whitish flakes, serosanguinous discharge present. Profuse external urethral meatus, glands penis couldn't be distinctly visualized. Proximal skin appears to be edematous. Scrotum appears to be normal with the normal rugosity, with no swelling or skin changes. In palpation, inspectory findings are confirmed, non-tender, bleeds on touch, hard in consistency, base indurated, extending beyond ulcer margin up to the midshaft, urethral orifice obliterated by the growth. Scrotum, bilateral testis palpable, normal. Examination of the inguinal regions, bilateral multiple inguinal nodes palpable, largest measuring around 1.5 x 1.5 cm on the right side. No fixity or matting. Firm in consistency. Tenderness present. Digital rectal examination. Perianal region normal. Normal sphincter tone. Normal fecal staining. No prostatomegaly. Systemic examination. CVS S1 S2 present. RS bilateral air entry present. No added sound. Per abdomen soft. No organomegaly. Case summary, 71 years old gentleman presented with the complaints of ulcero-proliferative growth over the distal penis for the past 6 months. On examination, an ulcero-proliferative growth of size 4x4 cm involving profuse glands, coronal sulcus, and distal shaft of penis, irregular in shape, irregular margin, everted edges, base indurated, bleeds on touch, hard in consistency, with a bilateral multiple inguinal lymphadenopathy. Probable diagnosis, carcinoma of penis, TNM staging T2, N2, M0. Stage grouping, stage 3B, Jackson staging 3.
So, for a PG, usually carcinoma penis, it is even for an undergraduate, it is a spotter light. So there is nothing much to find out a diagnosis or struggle to get a diagnosis. Diagnosis is sitting at your eyes. So it is only the staging and the further management that is a big discussion that will go on in a PG. Even it's a, of course, when you have a lot of cases, this may be given as a short case. When you don't have cases, you may be given this as a long case. But normally it is a short case. And in the exam, the discussion of how you are going to manage, that is very important rather than the diagnosis part of it. So you proceed with how we are going to manage the case.
First of all, I like to diagnose the tissue diagnosis. I will prefer the patient incisional biopsy from the edge of the ulcer. and unlike to the pathological staging
It
and
is
grading
not
of
an
the
incisional biopsy, it is just a punch biopsy. See, it's a cauliflower-like proliferative growth. Why do you want to put an incision? You are not going to put an incision at all. You have to avoid a necrotic area, take a healthy or a area at the edge where you take a punch biopsy. So that will give you a biopsy.
Okay.
Incision means, incision biopsy means that you have to enter the skin and down you have to take a biopsy. That is only called as an incisional biopsy. A proliferative growth, which is externally present, it is not called as incisional biopsy. Either it is a punch biopsy or a edge biopsy.
Okay. And proceed with the pathological staging. Now, after that tissue diagnosis, I would like to nodal met staging and local diagnosis. For the local diagnosis and nodal met staging, most of the extension of the clinical examination, ultrasound for first done.
So,
pathological diagnosis will be likely.
Yes,
Ashok, one question. Suppose you have an ulcer of 4 centimeter,
yes,
you have induration. What is the significance of induration in malignancy?
Significance of induration means deeper tissue involvement, and induration is a margin for the dissection in a carcinoma.
Induration means infiltration.
Yes, sir.
So,
infiltration of the deeper.
When you have superficially a 2 centimeter growth in the tongue or the penis, the involvement could be much wider. When you feel, it could be 1 or 2 centimeters proximal or distal, as the organ may be. So, spread could be possible. When you give a margin, you must always give margin for induration. You should always check only from the induration, not from the growth. Okay. And what are the features to say that it is growth? I am saying it is a benign ulcer. You say growth, it is straight away looking at it, you can make a diagnosis. What impression gave you that it is a growth? Malignant growth in the sense, true sense.
Yes, sir. First, go with the age of the patient. If the patient age was 71 years age, and if the complaint was a short duration, 3 months duration, aggressive pattern of proliferation, and there will be associated with bleeds and touch on the swelling, and they are present with he presented with recent onset of phimosis for the past 3 months. Okay. And associated risk factors, he is a known smoker for the past 40 years.
Ulcer alone, on the basis of looking at the ulcer alone, they say it is a growth, malignant growth. What are the features? All these are supplementary on the basis of growth.
Yes, sir. On examination, patient growth were extensively involving the distal penis and growthing having the everted and rolled out edges and bleeds and touch, and induration present in the deeper structures.
Why there is aversion of edges?
The extensive proliferation present over the edges of the proliferation in the malignancy.
Madam asked you one question. Where will you take the biopsy? She said you can take biopsy. If you are given an option to do biopsy, where you will take the biopsy?
In the proven, in view of malignancy, we always take the biopsy from the edge of the proliferation region, because more proliferation present on the edges, and necrotic death tissue may be present on the center of the ulcer.
Second point.
Sir.
Second thing. Second thing is you can always compare it with the normal anatomy in the nearby area.
Yes, sir. The character comparison for the squamous cell carcinoma.
Normal area. Normal area. You can compare with the normal anatomy.
What is the histology of this carcinoma?
Sir, ma'am. Histology for this patient.
Histology. What sort of histology finding will be there in carcinoma penis?
In carcinoma penis, histologically, the patient may have the squamous cell carcinoma, basal cell carcinoma, melanoma, or the
the one you're now taking biopsy and suspect. What is the commonest one to come in the carcinoma pills?
To say it is a malignancy, keratin pills for the squamous cell carcinoma and basement membrane breach and perineal invasion and limbovascular invasion.
Oh, that can be there, that may not be there. But
Yes.
squamous cell carcinoma is the commonest type to have come in the carcinoma pills.
Yes.
So rest of the things are rare ones. Okay.
Okay.
So then
I can proceed with the ultrasound for the extension of the clinical examination. For the local diagnosis, the involvement of the ulcer to the deep.
What about you said about the inguinal nodes? What is the teaching about inguinal nodes regarding carcinoma pills? Are all nodes are always metastatic?
No, ma'am. The palpable lymph nodes present on the carcinoma penis, the malignancy could be 30%. In case of the non-palpable nodes present on the inguinal region, there may be the occult mets 5%.
No, even the palpable nodes. Do you think all the time it is malignant deposits?
Only 30%.
So what do you do?
We confirm with the malignancy by the FNAC of the node.
Okay, one thing. So the FNAC is inconclusive. What do you do?
FNAC inconclusive, we may proceed with the prophylactic superficial lymphadenectomy for this side.
Why prophylactic? Is there any role for prophylactic?
Ma'am, we can examine the we can access all the nodes and examine the inguinal nodes that can predict the malignant metastatic to the nodes.
What is carcinoma penis with lymphadenitis? The commonest teaching is it can be an inflammatory, because you say it is a ulceroproliferative growth. There might be some amount of a secondary infection.
Superadded infection.
So the teaching is always that you give antibiotic for 3 to
4 weeks.
4 weeks. Then if the node is still persistent, you can repeat FNAC, or you can take a sentinel node, and then only you proceed. Not that every time the prophylactic lymph node dissection is not done for carcinoma penis.
Yes.
Okay. So biopsy from the ulcer is proven as squamous cell carcinoma, and then your nodes. So you have multiple nodes, and your node status here is, you say, N2. Why do you say it is N2?
In TNM staging for the carcinoma penis, N staging were N1 with mobile inguinal nodes and N2 bilateral multiple nodes.
So the patient is having multiple bilateral nodes.
Yes, ma'am.
He is having bilateral.
Yes, ma'am.
Okay. So what other imaging you need to do further?
First I like to start with the ultrasound of the penis and inguinal region, ma'am.
Ultrasound of penis, why?
It's an extension of the clinical examination and tells involvement of the depth of the ulcer infiltration and tells about the malignant.
What is it going to help you to know the depth? You want to know whether you can bear him with a shaft.
Yes, ma'am.
So that is not going to give you anything with your ultrasound. I don't think ultrasound of the penis is going to help you.
It's for the extension of the clinical examination only, ma'am. For the confirmation of the best modality to investigate the tumor infiltration and the nodal status, the contrast the MRI will be more beneficial.
No. See, carcinoma penis involving tulcus and shaft, you said. Okay.
Yes, ma'am.
And induration is present even after the ulceroproliferative lesion for 2 to 3 centimeters. Okay.
Okay.
So that is enough. That is enough about the penis. What about the investigation to know that the lymph nodes beyond the inguinal region is involved?
Ma'am,
beyond
we
the-
have Professor Karthik sir also with us, madam.
Okay, sir. Dr.
Thank you,
Karthik,
madam. Thank you.
please carry on, sir.
the better know the lymph nodal status, we can go with the CECT pelvis and distant metastasis.
For a palpable lymph node, what you are going to do, and for a non-palpable lymph node, how you are going to assess the lymph node mets.
For bilateral palpable nodes, we can proceed with the FNAC of the nodes, and in case of positive for the FNAC for malignancy, bilateral iliac block dissection.
You have to tell about at least dynamic sentinel node biopsy is done. For a non-palpable nodes, you go for a dynamic sentinel node biopsy.
Sir, I only
For
tell
a
about
palpable, as already madam said, you have to put a course on a prophylactic antibiotic and you reassess, and then you go for a final aspiration cytology.
Yes,
right. For a local area, what is the role of MRI? You said some role of MRI. Is it? The role of MRI.
Yes, sir. MRI will be the most beneficial investigation for the carcinoma penis regarding the depth of invasion in the carcinoma penis. It will tell about the infiltration into the carcinoma, corpus cavernosa, spongosa, and urethral involvement better with the MRI contrasting.
Urethral involvement, can you identify by your examination or by your history? Can you identify the urethral involvement?
In the history wise, patient tells about the voiding disturbance and the disturbance in the stream of the urine.
What disturbance in the stream of the urine you'll get if you have an urethral involvement?
Thinning
Whenever
of
patient says a multiple streams of urine, like a shower,
yes, multiple streams, yes, doubling
have an urethral involvement.
Double
But
stream.
again, if clinically you have a palpable iliac,
palpable urethral involvement,
that there is an
it can be examined bulbar and bulbar urethral.
Have you mentioned about the digital rectal examination in this case? Is there any
yes,
role of digital rectal examination?
In digital rectal examination, adjacent spread to the prostate can be examined, and pelvic nodes can be examined.
Okay, proceed.
Ma'am, after the confirming the diagnosis with the MRI and the nodal status, in this patient, for this patient, I can go with the tumor board discussion and counseling with the patient.
Hello.
Sir? Sir, can I yes, sir. After confirming the diagnosis by the tissue diagnosis and nodal metastasis and the distant metastasis rule out, we can proceed with the patient for the management.
Is there any role of your immunohistochemistry here? You want to do any special stainings to rule out any risk factor that will help in
immunohistochemistry
targeted therapies like that? You want to complete that investigation also now?
Human papilloma.
Human papilloma virus related as a risk factor, you have to do a special stains for an immunohistochemistry, which will help you for a targeted therapy.
Target therapy, HPV related.
Yes, proceed.
For the local diagnosis, we can use the MRI with the contrast, and distant metastasis, we can proceed with the PET-CT from the base of skull to mid-thigh. After confirming the diagnosis, and we can proceed with the management. For the management, I like to send the patient for the tumor board discussion and patient family counseling. We proceed for this patient. I would like to proceed with the management of partial penectomy with bilateral inguinal block dissection.
You want to do partial penectomy?
Yes, ma'am.
What is the involvement? What is the length of involvement? You said it is involving more than?
Involving the tip of penis to the mid-shaft.
Mid-shaft as well as induration beyond that, you said. So, will you be able to give a good stump after taking care of the margins?
Ma'am, in the view of malignancy, we always remove the tumor up to the clearance of 2 millimeter, at least 5 millimeter of the clearance from the intraocular margin.
Okay.
After the clearance, if it is preserved with 2.2 to 2.5 centimeter stump, it will be more beneficial for the patient for the functional and emotional support.
Yeah, but all you are able to give a good stump.
Yes.
Of a reasonable centimeters, it is okay. Otherwise, it is better not to have a very small stump, which
Yes.
is not going to give him any use, even for urination purpose.
Yes.
So you have to weigh that.
Yes.
Then with the oncological principles and the margin clearance, how much you are going to give him as a margin.
Yes.
Okay.
Yes.
So here you will be able to give him a good margin, good stump.
Yes, ma'am. After the partial penectomy and bilateral inguinal
Suppose you have a doubt that you may not be able to give a proper margin, pre-margin. Can you ask for a frozen section?
Yes, ma'am. In most micrographic surgery can be applied, and frozen section for the every margin that will prevent the further amputation of the penis and preserving the most accessible length.
What is how the involvement of urethra is there in carcinoma penis? When will it get involved?
The breachment of the buccal fascia rare, but after the breaching the buccal fascia, the urethral involvement may be present.
So urethra gets involved last. So always when the urethra is involved, it is the involvement of the whole thing like a local advanced disease. So urethra is always spared, okay, till the end.
Yes,
You have to tell about how the spread occurs. What are the two ways of spread that occurs for a carcinoma?
Local spread or lymph node.
Okay, which is early?
Sir, local spread.
No. Lymphatic spread is early. As direct spread is late. What is the reason for late direct spread? What is the reason for late direct spread? Because of the presence of the buccal fascia, as you said already, that is the reason for the late direct spread.
Late direct. Okay. So after done with the partial penectomy and bilateral inguinal block dissection, the specimen of the inguinal block dissection nodes were examined. If it is more than 2 nodes, I would wait for the 4 to 6 weeks and proceed with the pelvic lymph node dissection.
No, you want to do a partial penectomy plus that is for the local part. What you want to do for the node, for the bilateral case?
In the bilateral
node, there is a bilateral now. What do you want to do for both?
Yes, sir. In for this patient, the bilateral inguinal node involvement, multiple bilateral inguinal node involvement present. For that, we proceed with the bilateral inguinal block dissection, sir.
No, you want to do only an inguinal block or ilioinguinal block? How you decide?
Yes, sir. Ilioinguinal block dissection.
Is there any other modality of treatment?
In case of early benign carcinoma, we can manage with the conservative management. In another advanced carcinoma, we may be tried with chemotherapy or radiotherapy, chemoradiation. In early carcinoma penis, we can conservatively manage with 5-fluorouracil and immunocomoid ointment for this patient and EBRT may be used, and circumcision in the only the propusural environment, maybe the circumcision only enough for this patient, and glandectomy, glands reposition, or the patient having the ulcer over the shaft of the penis, excision of the wide local excision of the ulcerative growth, and covered with full thickness skin graft.
No, I had asked, is there any other modality? What are the other modalities that we can?
For this
you have to tell about the other modalities.
For
if
this
you want to tell about all the type of treatment, at least you go by stage by stage. For the, you had applied on Jackson stage, you tell what you do for a stage 1, what you do for stage 2, and stage 3, like that you have to tell.
Okay, sir.
Yeah, I'm asking why you are not saying a word about what is any role of radiotherapy for this case. Want to give for a radiotherapy or not?
So, radiotherapy may be tried in, sir. Radiotherapy and local control of the partial penectomy with surgery. Radiotherapy and surgery role may be in clinical trials, sir. There may be same outcome, sir.
No.
Yes, sir.
For this case, you had opted for surgery as a first treatment. Yes, I'm asking why not radiotherapy?
Arjun radio. For this patient, radiotherapy may be tried in, sir.
Radiotherapy or not? See, normally for any squamous cell carcinoma, we say that radiotherapy is the first option for treatment. That's what the teaching says. But why we are not selecting an radiotherapy as a first modality like this ulceroproliferative growth in the penis? We are going for surgery, not radiotherapy.
Sir, patient old age may be not tolerating the radiotherapy doses, and
normally squamous cell carcinoma arising from the penis usually will have a secondary infection. Usually squamous cell carcinoma with a second infection are usually radio resistant. Number one, you need more amount of radiation to treat. Once you give more amount of radiation, automatically it will end up in radionecrosis.
Okay.
Madam, kindly unmute, madam. Is mute.
Can you, have you heard of brachytherapy in the form of penile mold?
Yes, sir. Yes, ma'am. Penile mold, yttrium and iridium may be used for the penile molding, and interstitial radiotherapy for this patient.
Interstitial radiotherapy.
Yes.
What is the indication for that?
No.
Indication?
Radiotherapy was on clinical trial, ma'am. It may be EBRT may be used in the early penile cancer and in advanced penile cancer. Okay. In advanced penile cancer, there may be unresponsive to chemotherapy. Maybe we try the radiotherapy.
Ashok, just want to give one basic principle. Generally, brachytherapy is given for lesions to increase the dose of irradiation and also reduce the side effects to the surrounding organs. Penis and cheek are one lesions where you can try brachytherapy, where high dose radiotherapy can be given to the lesion without affecting the surrounding tissue. Similarly, surgery is considered mutilating in the penis. So those who want to preserve the form and function of the organ, it's one such therapy, as madam pointed out, is brachytherapy. Penis is one thing which is called penile mold can be created, in which brachytherapy can be tried. In that, you don't do any mutilating surgery on penis. It can be attempted on early, as you rightly said, brachytherapy is for early lesion, and teletherapy or your EBRT, external BMS RT, is for advanced lesions, which you cannot. So that is the reason. Okay. So you have that principle. This is applicable in case of CA tongue, CA cheek, all oral cavity malignancies, and squamous cell carcinomas, and also the only thing is you preserve the form and function of the organ to a great extent, comparing surgery where there is a tissue loss.
Okay.
Oh, so what is where do you decide about a inguinal dissection and ilio-inguinal dissection? What made you decide between the both?
In the non-palpable inguinal node patients, we can go for the dynamic sentinel lymph node biopsy. In case of presence of one positive in the dynamic sentinel lymph node biopsy, we can go with the yes.
So when nodes are palpable and metastatic, you have to go for ilio-inguinal biopsy.
Yes.
Wow. I mean, what is the indication for total penectomy with perineal urethrostomy? For completion's sake, we are asking this.
Yes, ma'am. In case of patient extensively producing proliferative lesion, we can't preserve the stem of the 2.5 centimeter for this patient. And involvement of the scrotal skin, we can proceed with the perineal urethrostomy and the excision of the total penectomy with the archectomy and scrotectomy.
Architectomy is a must?
Archectomy, not must.
Why scrotal skin you are telling? Scrotal skin gets involved in penile cancer?
No. No, ma'am.
It's not common. Huh?
Yes, ma'am. Yes, ma'am.
So when you are not able to give a good stump, when you are not able to give the function of the penis to some extent, you want to give a good clearance as per archaeological principles, you do total penectomy with a perineal urethrostomy. Okay. Architectomy is not mandatory.
Not mandatory.
So what is the complication of perineal urethrostomy?
After the post-op complication of the perineal urethrostomy is uremic dermatitis due to the patient continuously in contact with the urine, in the perineal skin, and urethral stricture may be present.
Urethral stricture is the complication which is encountered after a perineal urethrostomy, and the patient needs to have frequent dilatations.
Yes.
Dr. Ashok sir, you can take.
In this case, if you have no node, now you
Madam, JLL sir also has joined, madam. JLL sir. Good afternoon, sir.
Sorry, I was held up.
Sir, good evening, sir.
Good evening, madam. Thank you.
You can take over, sir. We can also learn.
Go ahead, madam. Sir was asking. No, so.
Sir, good evening, sir.
Good evening. The node is positive. What you are going to do? That is what sir is asking.
If this case, if you don't have any node, as such any node is there, you do a partial penectomy. The same case you receive after a year with an right side inguinal node.
Yes, sir.
How you will manage?
We can first manage with the palpable nodes present on the unilateral side. We further.
I want to know whether you want to go for a unilateral block dissection or you will do a bilateral block dissection.
Bilateral block unilateral block dissection.
Unilateral block dissection is sufficient whenever you have a metachronous lesion. If you don't have any node at the same time, you have a node at a later stages, you go for a unilateral block dissection.
Yes.
In case of advanced carcinoma of penis, how a patient will die?
The most common cause of the carcinoma patient will die in the advanced stages was malignant growth in the nodal means causing the encroaching of the femoral artery and the external artery.
Okay.
Ashok, your case is T. What lesion? T?
T2 N2 M0, sir.
What is TA lesion?
TA lesion, non-invasive squamous cell carcinoma.
So what are the cancers you will get TA lesion?
In non-invasive squamous cell carcinoma, it's a type of.
Any cancer you have in a AJCCV staging, what are the cancers you have this TA staging? But no, all the cancers you don't have a TA staging.
Yes, sir. Verrucous type cancer.
When is carcinoma penis, you get a uninvasive.
Sir,
Any
another TNM staging for bladder and PA bladder.
So that's papillary carcinoma. Also, there will be that. What is the significance of that T1A and T1B?
The T1A, T1B in the TNM staging was with T1A means without lymphovascular invasion and perineural invasion, and not a grade higher grade. In the T1B with lymphovascular invasion and perineural invasion and the tumor high grade, grade 3 or a sarcomatid variant. In the model means risk in the T1A which is higher with a 30% risk, and T1B will be the high grade. High risk for the lymph node metastasis with a 70% of risk.
So what is the significance? Even if you have T1A, you may skip
lymph node dissection may be avoided in the on observation in the T1A.
With the T1B lesion, there is no node. How will you proceed?
T1B lesion with non-palpable nodes, we can move the sentinel node biopsy or a dynamic sentinel node biopsy. After confirming the malignancy to the node in the sentinel node biopsy, we can proceed with the nodal dissection.
So you are doing what dissection you will do? You will do pelvic dissection or inguinal dissection?
Sir, inguinal.
So what is the indication to proceed to pelvic lymph node dissection?
Pelvic node dissection in the inguinal node dissection, more than or equal to two lymph nodes are positive, we can proceed with the pelvic node dissection, or else in the CT abdomen, skip lesion to the pelvic node nodes present on the CT, we can proceed with the pelvic node dissection.
Can a carcinoma penis produce skip lesion?
In case of gland penis, the tumor lymphatic spread to the straightly goes into the deep nodes of the femoral node, deep inguinal node, and it can directly goes into the external abdomen.
Good. And how do you go ahead with it? What type of lymph node dissection you will present?
For this patient,
yes.
For this patient, bilateral inguinal node dissection, sir.
What
I would like to prefer the catalog of modification inguinal node dissection.
What is that modification?
The previous classical inguinal block dissection was a boundary with the inguinal ligament and superior inguinal ligament and laterally with the sartorius, medial part of sartorius, and medially by the lateral part of the adductor longus. And in the modification, dressless quadrangle was bound by the anterior superior iliac spine to the pubic symphysis and the superior, and 20 centimeter from the anterior superior spine to lateral, and 15 centimeter from the pubic symphysis to medial, and the imaginary line joining the two inferior points.
So you will do catenona modification where you are going to preserve, only work medial to the femoral artery.
Yes,
so
sir.
what are the why do you want to choose from a dressless to catenona?
In the classical inguinal node dissection, there may be existence of the GSV and in a sartorius transposition needed for the covering. In a catenona modification, there may be preserving of the GSV and there is no need of the sartorius cover.
Why do you want to do that? To prevent what? What is the most dreaded complication which you get with the lymphadenectomy?
In lymphadenectomy, femoral vessel injury.
Blowout.
Vessel blowout is very rare. Common complication of any lymphadenectomy.
Any lymphadenectomy, sir, is a flap necrosis, sir.
Necrosis also less. Okay, yes. One cause. So all this is mainly to rule out the lymphedema.
Yes, sir.
Following the lymphadenectomy, what you are going to get is the most is lymphedema.
Yes,
What are the other modifications, recent advances there to get lymphedema reduced? What is the minimally access surgery?
Minimal access surgery for lymph node dissection.
Lymph node dissection. So you are not okay. That is now the new technique, minimally invasive surgery for the lymph node dissection, like actually node dissection.
The incision was only 3 cm and dissecting inguinal node dissection.
No, minimally invasive. You do the routine way. Any other method to prevent the lymphedema?
To prevent the lymphedema, we can use the tensor fasciolata flap, or else using the thickness of the flap will be thicker, and preserving the ligating the individual lymphatic vessel with the silk.
So suppose the tumor, you have a N3 node. What is N3 node?
N3 node fixed and our pelvic node, so fixed inguinal node.
So when you have N3 node, how you are going to proceed?
In more than 4 cm fixed on pelvic node, we can manage with adjunct chemotherapy, sir. After the adjunct chemotherapy, if it was responding, we can proceed with salvage inguinal block resection. If it is not responding, palliative RT may be trained.
So any role of preoperative rate RT?
Sir,
preoperative RT.
Sir, radiotherapy and clinical trial, sir. The survival benefit of the patient was in surgery and radiotherapy equal.
For a node, preferably
for node
radiotherapy. The patient has a pain and more than 4 cm. It is not pre-surgery you can't do. Better to go for radiotherapy, external beam radiotherapy. Then after assessing that tumor, either you can go for lymph node dissection or you cannot go for the lymph node dissection.
Yes, sir.
What are the stages where you do the organ preservation?
Sir, organ preservation done with TA and TIS carcinoma in situ lesion and T1A lesion.
What are the options you have?
Sir?
What are the options you have for organ preservation?
Sir, in the organ preservation management, we can go with the circumcision for the only perpetual involvement of the carcinoma. And in the only involvement of the glands, we can go with the glandsectomy. Or in the ulcer present with the shaft of the penis, we can go with a wide local excision and cover it with a full thickness skin graft. Or in the glandsectomy and with the reposition of the gland. Sir?
Non-surgical option.
Non-surgical option in a 5-fluorouracil cream and imiquimod kim for the topical application, and local external beam, the pineal mold radiotherapy may be trained.
Pineal mode?
Sir, the interstitial brachytherapy, interstitial radiotherapy.
For pineal mode, what is the indication for external beam radiotherapy? So penis is one area where a lot of areas where you talk about that 4 cm module. So when there is a superficial lesion, you have the glands, it is only 4 cm. This is a maximum limit you can include in the mold if you are using.
Mold. Yes, sir.
When it is more than 4 cm, you have to
more than 4 cm lesion.
Any laser therapy?
Laser therapy we can use with gas laser CO2 and solid laser Nd:YAG and KTP.
So how do you prefer carbon dioxide or Nd:YAG?
Sir, Nd:YAG maybe not.
So it depends upon the depth of the lesion.
Sir, penetration will be 1 to 4 millimeter in the Nd:YAG laser.
Nd:YAG you can give when thickness is more, you can give for that.
Yes, sir.
What is Young's operation?
Sir, Young's operation, partial penectomy with a bilateral node dissection. Young's, sir.
So how this suppose the urethra is involved,
Okay, sir.
How it affect the stage?
In AJCC 8th edition, the urethral environment may be urethral environment added to the TNM staging in a T. In T2 was environment corpus spongiosum environment with or without a urethral environment, and T3 corpus cavernous environment with or without a urethral environment.
So it is not going to affect the stage.
Yes, sir.
It is advantage or disadvantage. Urethral involvement is very late in carcinoma penis.
Yes, sir.
It is advantage or disadvantage. Why urethral involvement is late in carcinoma penis?
The thick bug fascia prevented the spread of the malignancy to the urethra.
Okay. So when you are doing what surgery you will want to do for this case?
Partial penectomy with bilateral inguinal node dissection.
So what are the vessels you will encounter there?
In partial penectomy, in the superficially, in between the skin and bug fascia, dorsal superficial dorsal vein of penis will be encountered first in the dorsal aspect, and after the bug fascia, we in the middle we encounter the deep dorsal artery of the penis in the middle, and in a bilateral the right and left branches of the deep dorsal vein present.
So you mean to say the center will be artery, the left is next is a vein.
Central vein, the bilateral artery.
So always remember the vein relationship. The
Yes,
vein,
sir. Central vein,
nerve.
bilateral artery, and laterally.
You have the nerve. What nerve? The nerve and artery comes from where? Artery is a branch of?
Artery, all are branch of the internal pudendal artery, sir. Branches from the internal pudendal artery, which is the branch of the anterior division of the internal artery. In the sensory supply of the penis by the
erection of the penis is maintained by what nerve, and ejection is maintained by what nerve?
The ejaculation is maintained by the nerve irrigandis S1, S2, S3, sir. Erection of the penis pudendal is inferior hypogastric process.
What is the skeletal nerve?
Sir, inferior hypogastric process.
So how when will you remove the testis from this machine?
Sir, testis removal not advised, sir.
Why? What is the indication for removal, or what is the why people are advised to remove the testis, and how do you prevent that?
The removal may be beneficial for the avoidance of the uremic dermatitis in the penis and repetitive encounter the skin dermatitis due to the urea contact.
Then during the surgery, then how do you make the testis to get elevated?
During surgery, VY advancement.
So suppose the patient is not willing for surgery, is not amenable for any conservative management. What is the option you have now?
Try with the chemo radiation.
So what is the chemotherapy you use normally?
In the carcinoma penis, like to use the tip regimen, sir. Paclitaxel, ifosfamide, and cisplatin.
Suppose the case is given in the early stage, and what do you think what are the pre-malignant conditions you will think about?
The pre-malignant condition for the carcinoma penis were divided into two. HPV related and non-HPV related. HPV related condyloma acuminata and Buschke Evans tumor. Non-HPV related cutaneous horn
What is
pseudo
the difference between condyloma lata and Buschke Evans tumor?
Condyloma lata are papillary, solitary papillary lesion, elevated lesion that's not reach the basement membrane, and Buschke Evans is a Jain condyloma acuminata. It's a locally destructive and mechanically compressing, and it is also non-mutant.
What is condyloma acuminata?
Soft solitary papillary lesion.
This is all HPV related. Anything else other than that HPV, anything else can produce that condyloma? What is the lesion you get in the penis on the secondary syphilis?
Condyloma latans. In secondary syphilis, condyloma lata. Sir?
Condyloma lata is a Buschke Evans tumor?
Sir, sir. Buschke Evans tumor is a Jain condyloma acuminata.
So that is produced by human papilloma virus.
Human papilloma virus. Both are occurred by the other than that cutaneous horn, which is a keratotic plaque present over the superficial, and it may be containing the invasive lesion in 30%. Other reason pseudo epitheliomatous necrosis and
comes from where? Cutaneous horn comes from where? Cutaneous horn is a result of what?
It's a keratin plaque due to underlying invasive hyperkeratosis.
That's a one common mistake PGs make is always thinks that the sebaceous horn.
Yes,
so there is nothing called sebaceous horn. Sebaceous gland will never produce a horn. It is always the cutaneous manifestation from underlying other malignancies.
Yes.
Oh, cutaneous horn. Then?
And pseudo epitheliomatous keratotic baronitis. And baronitis is xerotica obliterans.
What will be the feature in baronitis xerotic obliterans?
It is white is a color discoloration in the tip of the profusion and gland penis. The inability to retract primos may be there, and thickened profusal skin presence.
Good. So what is the Bowen's disease?
Bowen's disease, the erythroplasia variant of the Bowen disease in the shaft of the penis. It is categorized in the TNM staging as a carcinoma in situ.
No, what? How will you describe a Bowen's disease?
Sir, reddish patches.
What is the difference between erythroplasia correct and Bowen's?
Prevention.
Bowen's disease and erythroplasia correct, what is the difference?
The erythroplasia correct will be on the profuse and gland penis. Bones will be present on more on a shaft of the penis.
What is the common site of Bowen's disease?
Bowen's disease can occur mucocutaneous region anywhere in the body, in the oral cavity or.
Bowen's disease will not occur in the mucocutaneous. Bowen's disease. What is extramammary Paget's disease of the penis?
Extramammary Paget disease of the penis in the penis will have the underlying malignancy. Intra-epidermal adenocarcinoma present in the skin and underlying malignancy.
That is the basic difference. Any Bowen's and erythroplasia will be always the cutaneous manifestation of the underlying squamous malignancy. Paget's disease is always the cutaneous malignancy of the underlying adenocarcinoma. Normally, Paget's disease you get in the breast. You can get in the penis also. Either the apocrine gland and other gland which will produce the lesion. You can get it there. Then, any other lesion? Just a common. When you are talking about erythroplasia, everything else you have a common.
Leukoplakia, sir, not So not a pre.
Leukoplakia is a pre-malignant when it has an ATPR. Leukoplakia per se, one of the component when you are saying that the ATPR is there, definitely
Yes.
it is a going for pre-malignant.
Pre-malignant.
What are the areas you can get leukoplakia?
Sir.
What are
Areas
the areas in the body where you can get a leukoplakia?
Leukoplakia, glands, penis, and propice skin, oral cavity.
Think of the female also.
Sir, yes, sir.
Any areas in the female you can get leukoplakia. You can get in the vagina and vulva also.
Vagina.
And, you cannot say. Is it a sexually transmitted disease, carcinoma penis?
Sir, no, sir. Carcinoma penis is not a sexual transmitted.
So carcinoma penis is caused by what? Human papillomavirus.
The predisposing sexually transmitted disease, a human papillomavirus, was a sexually transmitted.
Okay. Carcinoma cervix is also produced by same human papillomavirus. Carcinoma penis is also produced by the same. What strain? Which strain
Six,
of papillomavirus? Huh?
6, 11,
6 is benign.
16, 20, 6, 11, 16, 18. In a carcinoma penis, 6, 11, 16, 18.
6, 7 will not produce a malignant lesion. 6, 7 will produce a,
Six,
you have a
sir, benign lesion in a most common strain was 6, 11, 16, 18. Malignant lesion was more produced 16, 18. Benign lesion 6.
Benign is more in favor of 6 and 7 will produce a benign lesion. And 16 and 18 will be more in favor of the carcinoma cervix is also produced by the same. Though there are studies which also prove that husband and wife are having the same penis, there is some slight increase in the carcinoma cervix development, but still it is not termed as a sexually transmitted disease. It is not, the route of the spread is not well established, so you will have to only say it is not a sexually transmitted disease. So suppose that you have done a penectomy and the patient wants that I need to reconstruct the penis.
Yes, sir.
Is there any option for you?
The reconstruction person tried with a brachioradial flap, sir. Sir.
Go ahead.
Brachioradial.
So you may not be postgraduate at this level. You may not know. At least you must know that phallus reconstruction is a possibility with the urethral reconstruction, and lot of flaps and lot of mechanisms are put forward, and that we don't normally expect you to step, but you must learn that also. Phallus.
Yes,
suppose the examination in the recent development, they can ask the questions on the development. So you must know how to develop, how to make the erectile function, how to function urethral function. So all these things you need to understand. How will you differentiate a urethral carcinoma from carcinoma penis? A patient is coming to you, he says the bleeding for urethra is also there.
Yes, sir. In a clinical picture, picture will be more predominantly with first with the urinary stream disturbances, sir, and the hematuria will be on the urethral cancer. Sir. In a carcinoma penis, the patient present with ulcerative growth for the glands and predominant glands and coronal sulcus. And moreover, associated
second reason the carcinoma penis?
Second reason the carcinoma penis most likely more probably due to the perianal melanoma, perianal region melanoma.
So what is the presenting feature in terms of secondaries which is happening in the carcinoma penis?
In terms of
any carcinoma which is predisposes any other blood malignancy can predispose as a carcinoma penis?
Blood malignancy.
chronic lymphocytic leukemia is one of the precursor.
Okay.
Again, it can dispose the development. Any treatment
Okay.
for a skin condition? One particular skin condition treatment is also more prone to develop a carcinoma of penis. When you
So,
have a psoriasis,
psoriasis, the PUA therapy will be impact on the skin of the penis, sir. So we will be avoid the exposure of the penis by covering the area.
so myelomas, leukemias can also produce
Yes, sir.
priapism in the penis.
Yes, sir.
What is priapism?
Priapism is a painful continuous erection of the penis for more than 4 hours.
Okay, for more than 4 hours is one of the very common MCQs which is asked. How many hours is that? So it is well mentioned only in Bayesian law. So you must say this is more than 4 hours, but it will go up to how long it can tolerate. Suppose the patient comes to the priapism, 4 hours. Will you do on any treatment or anything? What is the time? Otherwise, the complication you attend?
It's a surgical emergency, sir. Priapism. In acute management, we can try to it's a differentiate between the ischemic and non-ischemic, sir. First, ischemic due to the occlusion of the dorsal penial artery in the hypercoagulable thrombotic state. In a non-ischemic, in the confirmation by the confirm the PaCO2 level and the aspirated blood in the corpus cavernosum, and we can manage it with the intracavernosal injection of the phenylephrine and sir,
You need to aspirate. There's a lot of blood.
Yes, sir.
No point
Yes,
in
sir.
injecting something.
First of all, aspirate the engorged blood in the corpus cavernosum and inject the
Malignancy, carcinoma penis, when we are talking, we should also think of priapism because the secondaries can present with that. What benign condition will present with the priapism in the younger age group?
Sir, sickle cell anemia in pediatric age group may cause the ischemic type of priapism.
Can present with the patients. Can I will sir time? Matt?
Sir, I think we can close, sir. Any other important points we can give us a closing comment and close, sir. Anything else pending, sir?
No, I think
Madam Sharda ma'am,
madam can,
Karthik sir. I think we have Karthik sir also. Karthik sir, Sharda ma'am, you please give your closing comments.
Karthik
Ashok,
sir,
do you want to ask any doubts or anything to be clarified, Ashok?
Sir, no thanks,
Karthik
sir.
sir. For a long time I'm seeing you from the SRMC. Okay. Trichy.
Who, sir?
No, Karthik sir, I'm Dr. Jailal.
Sir, sir.
Nice
Good
to
evening,
see
sir.
you.
Nice, sir. Nice, sir.
Ashok, sir is asking any questions you have.
Sir, no thanks, sir. No.
You presented well.
Yes, ma'am. Thank you.
Thank you. Dr. Kanagil
Thank you,
sir, I
madam.
think it was a very good session.
Thank you very much, madam. Thank you for joining. I thank Jailal sir for kindly contributing this student. In fact, it's a very late request, sir, and then we asked for a specific diagnosis, and in spite of that, sir was able to arrange the case. Thank you very much, sir, for giving the PG. I thank Professor and Head of the Department, SRM Trichy, Professor Karthik, sir. Thank you, Sharda ma'am.
Thank you, sir.
For Jonas and all the other faculty, Arasu sir, Rajavelu sir, and Nizam. Srinivasan sir contributed the first case. And on behalf of the TNSI, we thank all of you for contributing to this session. The next session will be in the month of May 6th.
Okay.
Thank you very much.
Thank you, sir.
Thank you, ma'am. Thank you.
With the permission, we call this session as a close, sir. Thank you.